We're going to have our panelists come up now, and they will be discussing the comorbidities of diabetes from a physician's perspective, and you'll be allowed to we'll have questions and answers. The panelist is Dr. Ann Banerjee, Dr. Barry Smith, Dr. Fred Ferguson, and the moderator will be a representative from Kings County Medical Center. So while they're coming forward, what I will do is I'll read you a little bit from their bios. Dr. Barry Smith is president and CEO of the Rogens Institute, professor of clinical surgery at Weill Cornell Medical College. He's attending physician at NYP, which is New York Presbyterian, Weill Cornell Medical Center in Manhattan. Dr. Mary Ann Banerji, she is professor of medicine at SUNY Downstate Health Science University. She's the chief of endocrinology at SUNY. And I have one more person. Dr. Fred Ferguson, he's distinguished teaching professor emeritus, School of Dental Medicine at Stony Brook University, associate professor, Department of Pediatric Medicine. We have a guest speaker coming forward right now, and he's on his way.
Hi, I just wanted to make a few brief remarks, and I'm sorry for the change up in the program. My name is Bill Jordan. I'm a physician with the New York City Department of Health and Mental Hygiene. And just before we get going on the panel, I just wanted to say how grateful I am to be here representing the health department, and also to apologize that Dr. Easterling, it turned out that he was going to be out of the country this weekend, so I came in his place. But I just wanted to say, that I'm so grateful for all the work that all of you here are doing to reverse diabetes and the impact of it on our communities. My own father had diabetes, and he was somebody who came over from Eastern Europe as a Holocaust survivor who had lived through the war as a young child. He was born in 1936, and then came as a refugee from Hungary in the 50s. I often think about the trauma that people experience from adverse experiences while they're in their young life, and how that leads to shortened life. And my own father, passed away when he was 66. And while I was in training as a physician, and it's something that really stuck with me, that even though he had done all the things that he was supposed to, he'd quit smoking, he'd cut back on unhealthy foods, and probably wasn't getting as much exercise as he would have liked. But it sometimes still isn't enough, and that at the health department we think about all of the things that we've been talking about. But we also think about the burden of diabetes as something that, as Dr. Blackwell was talking about, really involves the social determinants of health and all the things that people are exposed to. I think, as Dr. Blackwell mentioned, there are very strong links between the income of the neighborhood you live in, quality, affordable housing, access to affordable, healthy food, safe places for physical activity, and social support that all have a big impact on whether you develop diabetes and whether you're able to control it. And that a lot of these things, are also true for hypertension, for high blood pressure, which many people with diabetes have both and at the same time. So I really hope that we can join together in opportunities going forward in the future, whether it's getting the word out like we're doing today, expanding services, working in coalitions like the Central Brooklyn Diabetes Task Force on policy, and really supporting neighborhoods in reversing historic disinvestment that's happened in many of the neighborhoods that we live in and work in. I'll just say, as a few of the things that we have coming out soon, we have a upcoming media campaign with partner stories coming out early next year, and we have a new diabetes health bulletin that is just about going to press and has things in it like social determinants of health, including encouraging people to seek help by doing things including calling 311 if they're having trouble paying for food, housing, or medicine, and really addressing that these underlying issues are affecting our communities. We've also been working to expand services. I've worked with many of you in the room in terms of expanding access to services like the Diabetes Prevention Program, and we're excited that we have the most diabetes prevention programs of any city in the country because of the hard work of many of you, and also in partnership with the health department. I think one of our policy objectives has been getting Medicaid to cover a diabetes prevention program, and many of you have also participated in our diabetes prevention network, and I invite you to join us in an upcoming forum we're having on December 5th at Somos, actually, to talk about how we can get Medicaid to do a better job of paying for preventive services, not just treatment. And finally, I would say that supporting our neighborhoods has been really important to the work that we've done together, whether it's assisting bodegas and corner stores to sell and promote healthier options, or promoting adoption of food standards by the organizations that we work with, and also the amazing work that many of you have done around expanding access to things like biking in our neighborhoods and doing urban farming, and that our local offices in Brooklyn have had amazing community partners in doing some of that work. So I think it also comes down to basic investment in our communities, and you know, some of the work that we've done at the health department has been in working with our partners, particularly in Brownsville around the neighborhood plan, putting health at the center of anything that happens, whether it's investing in more housing, investing in better access to transit, that we know that those things have a major impact on everyone's health. So in closing, I encourage you to reach out to us at our local offices, whether in Brownsville, Bed-Stuy, or Bushwick, and to continue to partner us with this, with us on this work. As a public servant, I think that we do our best work when we partner with everybody in the neighborhood and when we are accountable to all of you. So thank you again for your time.
Thank you so very much for those encouraging words. It's nice to know that our Department of Health is available to us and is working hard to help us meet our goals in terms of diabetes. So thank you so much.
Good afternoon. My name is David Stevens. I'm a doctor. I'm a primary care doctor at Kings County Hospital. I'm happy to be representing that institution here. And it's a tremendous honor for me to be serving as the moderator for this esteemed panel. Dr. Banerjee, who has been a leader in education of doctors, students, and many, many, many patients at both Downstate and Kings County hospitals, and Dr. Ferguson. And I'd like both of them to just give a couple of minutes talking about the work that they each do. And while they're doing that, I'm going to ask everybody in the audience to think about what questions you would like to have for these medical professionals. Some questions were handed to me earlier, but this is definitely your opportunity to take control, and the questions that you have burning, this is the time for it. So, Dr. Ferguson, let you start.
Hi, I'm Fred Ferguson. I'm a pediatric dentist. You're probably wondering, what the heck is this guy doing here? Well, I'm going to give you that in my message. I've been on a journey since probably started in the mid-'80s. And in fact, it began with an incident with a patient, with a parent. I'm not going to go into that. I feel that I am unique to be here, and the message I'm going to give to you. I want to tell you about 3 things that I've done that I want to give you some cred about myself. In the late 70s, I began a very innovative program for dental care for people with special needs, from newborns to the end of life. That started my journey, in my opinion, about what's going on in healthcare. The second thing that happened to me, I was very fortunate that two plastic surgeons who began our craniofacial team at Stony Brook put me as a director. So that gave me a really great opportunity to work with preemies and newborns born with holes in their faces. And that kind of got me going a little bit further about the problem in healthcare. And then lastly, in the late 80s, a lot of kids, children, infants, were coming from New York City out to Long Island with pediatric HIV infection. And that really got me over the top. So in a while, you're going to hear from me an opportunity that I'm going to present to you. I'm also an entrepreneur, and I have been working on a process to transform healthcare. And I believe I'm going to say to you that I think you have a unique opportunity here. I'll get to that in a bit. But I was in practice till 2 years ago, and I left Stony Brook. I am the Assistant Director of Pediatric Dentistry at Interfaith Medical Center, working with David Miller, and I'm here because he couldn't make it. I appreciate the opportunity, and I'm looking forward to the few minutes we have together. Thank you.
Cool. You want me to introduce myself? So my name is Ann Banerjee, and I work at Downstate and Kings County, and mostly I do diabetes now. And it's one of the most interesting disorders and one of the most prevalent disorders. And I think with that, I'm going to turn it back to Dr. David Stevens, because he's going to run this show, and we need time for you.
Great. So again, I've got a table full of questions, but I want to also turn it over to you guys. I think we have somebody with a microphone floating around. Thank you. So raise your hand high if you've got a question. Somebody have a question? All right, so I'm going to start with one of the questions that was presented. The first one handed to me right as I got up here. How can people control their sugar cravings? So either of you want to take a stab at that?
I'll save mine to my
Okay.
presentation. Okay, I think I'll answer that best there.
So sugar cravings, well, I would ask, does anybody here have diabetes or know anyone or have any relatives with diabetes? And have you ever heard about sugar cravings?
Yeah.
Well, what is it? A sweet tooth? You really want to eat something sweet. And there's nothing that can stand in the way. And I think Eric Adams mentioned that. I think he did, didn't he? He said, it's basically like somebody's got you, is holding you to the sweet, and you can't do anything about it, and it's got you and you don't have it. So diabetes is stronger than all of us, and it takes a little bit of time to get over our sweet tooth addiction. And I really think it is an addiction, and he mentioned that there's a crack addict in the room next door, and there's somebody having fried food or sugar in the other room, and it's very hard to get rid of it. So I think the only thing to do is to probably eat a healthy diet when you have diabetes, not take too much of your medicine as you try and transition from a medication-based diabetes to perhaps more food-based diabetes care, but it takes a while to get over that. And sometimes it's because your sugar is actually low that you have a sugar craving. So you need to be able to balance a healthy food and not have so much medicine on board that you can't overcome it. So some of it's an addiction and some of it's really a low blood sugar, and you need to sort of treat it in moderation with the right kind of food.
Thank you. Again, raise your hand high if you have a question. Got a question out there?
Is diabetes an addiction? Is it genetic? Or is it malnutrition?
Did you hear the question?
Yes, is diabetes an addiction? What I thought I heard, is diabetes an addiction or is it just malnutrition? Is that what your question was?
Well, I gave you three options. Is it an addiction? Is it malnutrition? Or is it a genetic disease? And I'm saying that because some years ago, my doctor looked at me in the face and said to me, you have inherited diabetes, and I was over 50. And I thought, he has to be crazy. That's not making sense. So I insisted that I see a nutritionist. But I think that, and you know, I don't want to answer my own question. I want to give you the opportunity to answer.
Well, what I'd say is this is a dialogue. It goes both ways. And it is true that it is partially genetic, because some people will never get high blood sugar, no matter how much they eat and how much bad food they eat. But I think there's an enormous number of us that have a genetic predisposition if we're in the wrong environment, eating the wrong kinds of food. So yes, you may have a genetic predisposition, but if you're never exposed to bad food, you won't ever have diabetes. So I guess the answer is, what do you say?
Yeah, I experienced, so I'm a primary care doctor, and I have this conversation with patients, why me? Why did I get it? And you know, my best friend who weighs 50 pounds more than me and doesn't exercise didn't get it. And luck has a lot to do with it. And the way we physicians talk about luck is we call it genetics. But that's the case. So it's really all the above. And the other option is an addiction. And I think Borough President Adams also really talked about it. Yeah, I mean, I think food, the way we eat, is as strong a habit as anything else there is. And changing how we eat is really hard. So yeah, it's all of the above. Any other questions? Or I'll go to, let me go to one of the questions I was given. So this is, I'm afraid of needles. Can I get insulin any other way?
So can you deliver insulin any other way? Well, the answer is yes, but let me just first address the needle issue. You may be afraid of needles, but those needles are so fine nowadays. They're 35 gauge needles. They're about as large as a hair. And if you ever try to inject yourself, you'll discover it doesn't really hurt. So the fear of needles is really a fear, but it's not well-founded anymore. They used to be like bayonets, but they are no longer like bayonets. They're very, very fine, and they slide right in, and you have to use a sharp needle for it not to hurt. Now, what about other ways of delivering the insulin? There are many other ways. They're probably very much more expensive. There's an inhaled insulin version, but that also has its downsides because you're taking in a huge amount of insulin through an inhaler, which goes straight into your mouth and into your lungs. So you deposit a lot of the insulin into the lungs, and a smaller amount gets into the circulation. So one thing that happens is your lungs are exposed to insulin, which is a growth factor, and there's always been a concern for these growth factors to develop lung cancers. And the second thing is you don't exactly know how much insulin you're going to be getting into your bloodstream. So that's one issue about inhaled insulin that has been, it actually I think is a drug right now. And the other way to get extra insulin through an oral route is to take some of the pills that we have that make you make more of your own insulin, if you can do that. So does that answer the question of somebody who asked the question? Okay.
So the next question I'm going to throw over to Dr. Ferguson. I don't want to give him a pass here. Why don't medical professionals talk about healthy eating more?
One answer. We have a fragmented, busted sick care system, okay? And in fact, I'm going to show you a slide that shows you exactly kind of where we are and we tend to stay. But your physician has no more knowledge about their mouth than you have of yours. And that's a real problem. And we're going to talk about how to solve that. That's going to be one of the things, very briefly, I'm going to touch on. But that's really, an excellent question. Excellent.
So I'll take your question right next, but I want to ask a follow-up question. One of the things that I've learned practicing medicine now for a long time, is that we used to talk about nutrition, and sometimes we still do, as you need a nutritionist, you need a specialist. It's this very specialized area that a primary care doctor or a vascular surgeon can't get into because it's too complicated. And I think we've done a disservice to healthcare providers because I think anybody with a license ought to be able to talk about some of the basics. More fruits and vegetables, no sugary drinks. Can you comment on whether I'm oversimplifying it, or you think really it does come down to the basics?
I don't think you're simplifying it at all. And again, part of what I want to talk about or allude to is that, we don't have health care. In fact, when I give talks, I like to ask people, I like for somebody to tell me what health is. I've only had one person, since I've been asking that question, answer it just like that. Everybody else has to kind of search for it. But when I ask, well, what's care? What's the health care? Oh yeah, when I get sick, I go to my doctor. That's our problem. And that is, we predictably, I'm trying to get in my talk, we predictably allow ourselves to get to a place where we don't leave ourselves much options. In fact, you're not leaving your healthcare provider much options either. So again, I'd like to defer that until I give my presentation.
Great, thank you. Can we take the question from the woman in the green sweater?
We've been talking about reversing diabetes. How far into the process, like if you're already on dialysis, is it the plant-based still useful in reversing? I just want to know at what point is there like the plant-based, it probably could help, but it's not going to reverse.
Right, so I think that's a wonderful question. So in medicine, we talk about 3 stages of prevention. There's primary prevention, trying to prevent the disease ever from starting. There's secondary prevention, which is catching it early. And then there's tertiary prevention, is you have the disease, but can you prevent the complications? And I think that's what you're getting on. If you're on dialysis, is it too late? I've got my answer. I'll throw it to Dr. Banerjee, see if she has an answer.
Well, I think you're absolutely, that's very well stated. The question is, if you go on a plant-based diet, can you get off dialysis? I don't know the answer to that one, but you could prevent many of the other complications, or at least hold them to where they are and prevent the progression and worsening of, say, blindness or nerve disease, etc., or heart disease or hypertension. Does that answer your question?
So that ties into one of the other questions that somebody wrote out before, which was, does having diabetes mean that I'm at other risk for other medical problems? And as has been mentioned, most people with diabetes, what they will die from is heart disease. And actually, that's even more true of people on dialysis. They don't die of the kidney disease because they've got kidney replacement with the dialysis. But what they do die most frequently of is heart disease. And so anything that can reduce your blood pressure, reduce your cholesterol levels, will work, right? Physical activity still works even after you're on dialysis. And plant-based, do we have studies? I mean, we like to talk about studies, and you've seen some data. I personally have never seen a study of people on dialysis switching to plant-based diets. But if anybody's going to do it, it ought to be us. We should be the ones testing that. So I think that would be a wonderful study. There's a dialysis center run out of Downstate, run out of Kings County. We could do the research. But I can say, as a physician, there's no harm in trying. And from the way Dr. Adams, he should be a doctor at this point, right? The way Borough President Adams described it, the benefits are seen really in weeks to months. The blood pressure starts to come down, the weight starts to come down. I think I would do it speaking with their physician, but speaking, if it was my patient, I would say, thank you for asking, yes, let's try it. Other questions? One all the way in the back.
We have seen an increase in the number of children now developing type 2 diabetes, and quite often these children look overweight to obese. So will changing or adapting the plant-based diet reverse their diabetes?
So this is a very important problem that children are getting under-exercised. They're not out there playing with their computers, which are very addictive also. And they're getting obese and they're getting diabetes. And the scary thing about that is that these children with diabetes, young people with diabetes, or pre-diabetes or metabolic syndrome, or have many more complications and a much shorter lifespan than adults with diabetes. So when they get it early, they have a much more complicated life. And I think that's one of the things we absolutely have to change. And I think that's very reversible with changing diet and changing physical activity and changing the stress that they must be going through. And it's, I think, one of the major problems, because you don't need to develop a whole population, a whole generation that is doing worse. But I do think the diet will make a huge difference with these folks, and as will exercise. And there needs to be recess at school. There needs to be money spent on having physical exercise programmed and planned into the school day instead of having lunch at 10 o'clock in the morning, which they sometimes have in schools. And then, of course, they're hungry in 3 more hours, and then they have another meal and another meal. And many of these meals are not even at home. They're all at school with unhealthy diets. So you need to lead the charge in the community for the change like this.
Does any more questions? Bring it. So I have a question that I actually like the group to answer, because I've had some experience, and I'll admit this, I'll be completely honest. As a primary care doctor, I'm sometimes a little afraid to talk about plant-based diets with my patients. I talked about eating more fruits and vegetables with every single patient. I talk about physical activity with every single patient. But I'm a little worried they're kind of kick me out of my own office if I start suggesting that. So I'm going to ask by raise of hands, if your doctor, the doctor that you've known and have gone to for your health care, said, how would you feel about talking about a plant-based diet? Raise your hands if you'd say, well, let's talk about it. Okay, I don't see anybody kicking their doctor out of the office. So that's important. I'm going to take it a next step. Are you kicking your doctor out of your office? Or you have another question?
No, I just want to suggest that we call it plant-based meals, because diet.
I think that's a great way to spin it. So it's one thing for the select group of medical professionals who are here today. We're all we're converted, but we know most of our doctors aren't. And so the question I have again for the group is, how many of you would feel confident going to your doctor and say, hey, doctor, I want to talk to you about adopting a plant-based diet, and starting the conversation yourself. Raise your hands if you would feel confident doing that. So maybe that's kind of the way we get our doctors to start changing their habits, by bringing it up to them. There's a question in the back that I want to get to.
But, I mean, clearly we heard that the doctor is not trained to talk to you about a plant-based diet, or, I think that, I know with my situation, I insisted on meeting with a nutritionist. I think that everyone who goes into the medical field with a diagnosis of diabetes should be automatically referred to a nutritionist. Because if we understand clearly that the diet does have a significant, make a significant contribution to the outcomes of our health, then we must take that into consideration. I mean, the doctor, of course, wants to control the situation and to control, everything in medicine. But there's a nutritionist. The nutritionist should be the person should be automatically referred to the nutritionist, and I just think that that's the way it should happen.
So I think your comment is a good one. Is there a question that you wanted us to answer?
Is there a question? No, I was just responding. I was responding to what you were saying, because the thing is, should the doctor handle that, or should the nutritionist, who should already be?
So is the question, should the doctor handle the diet counseling, or should that go to a special nutritionist? Is that the question? Okay. Either of you guys want to take it?
I'll take it. I think that everybody is responsible for nutrition. And yes, you, the doctor sitting in the office, like Dr. Stevens, can launch it, or a nutritionist. Very often patients say, I can't take another morning off from work to see a nutritionist and to pay a copay. So I think that, but nutrition is everybody's responsibility. At least that's the way I would think of it right this minute. And plant-based nutrition should be taught and promulgated throughout the community at every single level, and supported by your doctors and the nutritionist.
So we're out of time for the panel.
Give our panel a round of applause. And you've been challenged to go and talk to your doctor with insight and wisdom.